As you can see from the opening slide, I'm a clinical professor in cardiovascular medicine here at Stanford University School of Medicine. I'm coming to you from Chicago, where I'm attending a conference. And I appreciate everybody joining in this evening. I'll talk about sort of understanding and fighting heart disease like cancer. As you can see, I've written a book that came out earlier this year. And so I'll be talking about a number of the themes that I go over in the book. And along the way, there'll be probably some further introduction around sort of my career that led to this book. And I think one of the things that I enjoyed doing this also is that I got to share stories from family and patients, as well as other scientists and clinicians in the field. So yeah, I think my goal here is really to try to empower as many people as possible with a modern understanding of heart disease and all the things that you can do to prevent and screen and treat. So we'll get started. I do have disclosures, as we'll talk about in a little bit, in some of my career journey. I support several startups in what's now called sort of the digital health space. So I'm chief health officer for a company called Toku and an advisor for another startup called Porter. I've been a long time advisor for the American Heart Association. They have a Center for Health Tech and Innovation. I also am a volunteer member of the board of directors for the National Fitness Foundation. And all the author proceeds for the book get donated to charity. So just a little bit, as I mentioned, a little background. I grew up in Brooklyn, New York. I went to Regis High School. I like to say I was sort of halfway between Tony Fauci, who went to my high school many years before I did, and then Colin Jost, if you watch Saturday Night Live, was another Regis High School graduate. I spent 6 years at MIT and started in electrical engineering, computer science, but got very interested in biomedical engineering. Actually spent a couple of summers at Medtronic, which makes a lot of medical devices. And so that was sort of one of my first introductions to the applications of engineering and technology to cardiovascular disease. So I then decided to come out to Stanford for medical school. I met my wife there and took her back to Boston. She was actually then a postdoc at Harvard. I was at Brigham and Women's Hospital for my medicine and cardiology training, and then coming back to Stanford and had basically a fairly classic academic medical career as a cardiologist there, starting as an assistant professor, and worked on, as you'll see a little bit more, working on imaging of the heart for early disease detection. So I ran an imaging program, then took on running preventive cardiology. That actually got me into this field of what was originally called mobile health, now digital health. And about 8 years ago, started to spend more time in the health tech industry. So I worked about 6 years for different Google companies, and the last few years trying to turn into product some of the research that we had actually done at Google. So let's start off with getting into heart disease and cancer and how there have similarities and differences, and how we can learn from how we approach cancer to hopefully improve the prevention, diagnosis, and treatment of heart disease. So in many ways, heart disease is worse than cancer, even though we tend to think of it as a less serious disease, but globally, it affects many, many more people. And this is a graph that actually looks at one of the things we had published with the Heart Association is, instead of just lifespan, is sort of what's called health span. So, how long do you live with good health? And so you can see either by mortality or this disability adjusted life years lost, that cardiovascular disease globally substantially outpaces cancer. I think the other data that I cite in the book, which, I was writing a fair amount of it during the pandemic, is over the main years of mortality from COVID, over 2020 to 2022, they were estimated anywhere from 7 to 14 million deaths due to COVID. About twice as many occurred at the same time period due to cancer. And you can see, 3 or 4 times as many due to cardiovascular disease. And one of the big motivations for writing this book was not simply that, we're not doing as well as we could in reducing cardiovascular disease around the world, but we have good guidelines for helping with prevention. And even in the United States, only about 1 in 3 eligible adults are receiving guideline recommended heart disease preventive therapy. So I really want to increase awareness of this and help people better understand and be able to get on the preventive therapy that they need and deserve. I mentioned there are family stories, and one of the things that really first started having me think about writing a book was when my father-in-law, who you see here, died of sudden cardiac death. So basically losing, obviously, such an important member of our family to cardiovascular disease while, I was a cardiologist. And he has a really amazing background in that he was an expert actually on measuring circulating tumor markers. So he was very well known, had written a number of books and many articles on early detection and monitoring of cancer. And we would actually then, as his career evolved, we would talk about how he had branched into looking at circulating markers for heart disease. And as you can see by the article here that he wrote with my mother-in-law, and you see the 2 of them there in the picture with my 2 daughters, that he had become quite expert on the science of heart disease. And you can see there's a quote here from the article they wrote: "Detecting early risk markers for heart disease is important to avoid serious or fatal consequences." So he had an understanding that there's technology for early disease detection. Unfortunately, he was not so good about seeing his doctor and acting on the seriousness of this. And so unfortunately, he had sudden cardiac death. And at the time, my daughters were quite young, as you can see, and it was really pretty devastating for our family. And I really wanted that this shouldn't happen. We have the ways to prevent this, and wanted to get the word out. So obviously it's taken me a while to put all this together into the book, but I think, for my daughters, sometimes what's more motivating for patients is not doing something for their own health, but really for their family members, and to be around for important milestones of your family. So as part of the book, I really wanted my daughters to contribute some perspectives. Much of this they first wrote down quite a number of years ago, shortly after he died. And so my younger daughter had this to say, which was waking up one morning and having my parents tell me that you had died from a heart attack was one of the hardest things I've had to go through. For weeks, I couldn't stop thinking about you, thinking that I would never get to see you, hold your hand, or hear your voice ever again. The last time I said goodbye to you, I was only thinking goodbye for a few months, not forever. I told you I loved you, but I thought I would be telling you I loved you for many more years to come. I know you didn't choose to pass away early and suddenly, but I still wish you could have been around to see Kelly and I grow up. I also wish that I could have known more about your health and known more about how to help you, so I could have at least tried to keep you alive longer. And my older daughter, Kelly, who's actually becoming a cardiologist, wrote, "So why should you, the reader, continue reading the book? I could go on and list the facts about heart disease as the #1 cause of death in the US, but that isn't fully relevant. You should keep reading so you can make a difference in a life, whether it be your own or someone else's, so you can prevent a grandparent, parent, aunt, uncle, friend from dying suddenly, leaving too early from your life." So, with that background, I really want to start off in helping people understand first, what is heart disease? Why can it be so devastating? Um, this is actually a diagram that Da Vinci did many, many, many years ago. And it's of a woman's anatomy, and you can see right in the center is a heart. And I don't know if the arrow shows up well here, but you can see there's a sort of an oval-shaped thick part. So this is the main pumping chamber that pumps to your brain. And then the other side of it, what we call your right ventricle, is what pumps to the lungs. But the heart is a quite unique organ in that it has to do its thing every second to supply blood to every organ in our body. And obviously, if there's any problem with the heartbeat or with the pumping, then that impacts all the other organs in our body. What's also very interesting about the heart is that you'd naturally think that because the heart is filled with blood, that that takes care of the blood supply to the heart. But it turns out for us to be able to be upright, our heart muscle has to actually be quite thick to be able to generate a strong pressure to go to our brain and the rest of our body. And so the blood that fills the chambers is not enough to supply the heart muscle. So we have these arteries, which this is another Da Vinci's credited with really sort of discovering that the heart supplies its own blood supply. So the main aorta, where the blood comes out, there are smaller arteries that come off that go right back down along the surface of the heart. So you have, these tree-like structures that supply our heart muscle. And one of the key things about that is that these arteries that keep our heart supplied and keep our heart muscle nourished, they're only about 1/10 of an inch wide. And so you can see already that anything that compromises the heart arteries, it doesn't take that much because they're very small to begin with. And so, and they need to stay open to keep the heart muscle working. And this is a picture of an MRI scan. So one of the first areas that I got involved in from applying technology to detect heart disease was using MRI scan to non-invasively be able to take a picture. So you can see this larger round part is the aorta coming out of the heart, and then these small lines here are the sort of 1/10 of an inch size blood vessels that branch So this is the same left coronary artery that you see coming down the front here. And then you also have a right coronary artery going around to the other side. So we've talked about how we have these small vessels that supply our heart muscle to keep it beating all the time. And actually, pathologists, well over, about 150 years ago, had seen that, and even Da Vinci had noted that the vessels, as we get older and as we have disease inside the blood vessels, that they develop these growths. So what you see here is an etching from Virchow, where what I put in the box here is basically what should be your normal vessel, which is just the muscle part of it that allows the blood vessel to expand and contract. But you see here that, he had seen under a microscope that there are these big growths that happen in your blood vessel, and they have areas of inflammation, areas of cell growth, and the quotes from the translation, he indicated that this can cause destruction in the blood vessel wall, and the malignant term is the one that I've used and actually have used with patients. The idea that these growths, these tumors, as they were originally called, an atheroma is a form of fatty tumor, that these growths can really exhibit a lot of malignant features with being very biologically active and growing and inflamed and destroying adjacent tissue. It was actually, and this is now over 20 years ago, a colleague or several colleagues, one a cardiologist, one a pathologist, had actually proposed this idea: should we consider atherosclerosis, which is sort of our modern term for this, we also call plaque buildup inside the heart arteries. Should we be considering this a cancer of the blood vessels? So this is probably the key way to be really reframing how you think of heart disease. One is it primarily starts in our blood vessels that supply our organs, and particularly the coronary arteries that supply our heart, and that they are very biologically active growths, much more similar to a tumor. And, we use this term plaque buildup, which sounds more like what builds up on your teeth that you can scrape off. And it's really not nearly as benign as that. Sort of a more modern diagram of this is, a normal healthy artery. The red here is the blood flow, and you have this thin wall that looks good and as sort of similar to what Virchow had drawn. You have this layer of mostly muscle here. And, unfortunately, in the early part of my career, despite pathologists knowing the biology is very complex, we really got very focused on this idea that as plaque builds up, that it just gradually narrows the artery. And then when it gets severely narrowed, then we can go in with things like a stent or a balloon, or we can do surgery to bypass the area of narrowing. And so, technology could sort of take care of it. Of course, that doesn't explain why my father-in-law, for example, really didn't have symptoms of heart disease and then has a sudden heart attack and dies. So again, it took pathologists and scientists to sort of revisit this question. And what really happens is the artery develops inflammation and fat infiltrates, and you get these atheroma or very biologically active growths within the blood vessel wall. And one of the ways that it's actually worse than cancer is that these growths, while you still may have good blood flow, they can burst or rupture, and the normal response of your blood system is if it sees a tear or a crack or a cut, it forms a blood clot. But the problem here is the blood clot is happening inside your artery. And so you can imagine if this plaque bursts, the blood clot forms, it completely blocks the blood flow. And that's effectively what a heart attack is. Your heart muscle is then starved from the blood and oxygen it needs, and so the heart muscle cells die. So that's depicted here. If there's a blockage in this artery, then you get a heart attack or myocardial infarction. And if the heart attack is big enough, then the heart stops. And so that's sudden death. So that's why in someone like my father-in-law, he didn't have the gradual narrowing that could generate symptoms that we could have caught earlier. He had plaque developing inside the wall, not narrowing the vessel too much, but then had this plaque rupture and blood clot. And so suddenly he doesn't get blood flow to the heart and has a heart attack and dies. Well, so what are the other ways that, again, using atherosclerosis as the most modern term and cancer, how are they intertwined? And I should step back and say, the book talks about heart disease there, and the book does go into a number of different forms of heart disease, but the dominant form that causes the high degree of mortality around the world is due to this atherosclerosis, the plaques or atheroma that develop in the blood vessel wall that cause heart attacks. People who have heart attacks are then prone to heart failure, and the same plaque development and disease in the blood vessels can lead to strokes in the blood vessels that go to the brain or inside the brain. So while we talk about sort of heart disease broadly, the biggest impacts of that are heart attacks and strokes and all the medical issues that follow from those events. So yeah, I think a lot of people don't realize, and one of the things that was actually somewhat new to me, I knew all the heart disease or atherosclerosis risk factors quite well, but when you go to the American Cancer Society website, they list almost identical risk factors. So it turns out physical activity or physical inactivity makes you more prone for both heart disease and cancer. Many of these others are, well-known. Smoking certainly contributes to both. I don't think people realize that obesity is a risk factor for cancer. We'll talk more about alcohol, which used to be thought as more safe in low levels for heart disease or even beneficial. But now data indicates that alcohol is risk for both heart disease and cancer. And then diet is a contributor to both as well. We started to talk a little bit earlier with the pathology slide there that there's a lot of shared biology. So inflammation can help drive both plaque development and cancer. Immune function, as you may know, there are many aspects of modern cancer therapy that are involved in helping to manipulate the immune system, and there are similar efforts that have gone on for heart disease or atherosclerosis. There's a term called clonal hematopoiesis, which is sort of a mouthful, but it means that your blood cells are making clones of themselves. So similar to what, when it's more advanced, we would call leukemia. So there's effectively a form of pre-leukemia where you have higher amounts of circulating clones of your white blood cells. That is a fairly newly discovered risk factor for heart disease. And then angiogenesis, which is that when cancers grow, they need new blood vessels to form to feed them. It turns out when plaques grow inside your heart arteries, they also form small blood vessels within the vessel wall to help them grow as well. So it's an area that's been looked at to try to treat both cancer and heart disease. And then lastly, one of the things I'll touch on too is there's some shared imaging. So the most obvious is a chest CT, so a CAT scan of your chest that can be done for screening for lung cancer, is also sort of the main screening test we have for heart disease, because obviously your heart sits in the middle of the chest, so we're able to pick up both conditions at the same time. An area that's not as well appreciated is on a mammogram that the breast arteries have can have calcification, and so there's a breast artery calcification that can be detected, and that's an area that really should be looked at because it indicates an increased risk of heart attack. And then what's called a FDG, or a glucose-based PET scan, is one way to track tumors that are growing because they take up a lot of glucose. But it turns out researchers have shown that these inflamed plaques growing in your heart arteries also take up a lot of glucose. So there's a very active research on how do we image that biology within the blood vessel wall. So, the core of the book, and these slides get a little busy, but it focuses on, what are the key things you can do around prevention, screening, and treatment. The American Heart Association has what they call Life's Essential 8. I sort of split these into two parts. They're basically 5 of the 8 are really things that are more lifestyle aspects. And so they are the first 5 bullets here. And I know that there will be some questions, so but we'll touch on some of the things here, but happy to talk more in the Q&A. Key thing is obviously physical activity. People, I think, are quite familiar with. The guidelines are really to try to move 150 minutes a week of what's considered at least moderate activity, which is brisk walking, so about 30 minutes on most days. Eating healthy. The main kinds of diets that have been tested in randomized trials is a plant-based, what's called sort of a Mediterranean diet. So it tries to minimize, adds fish, minimize fatty meats, and includes nuts and olive oil. So healthy fats, controlling weight. So, when I wrote the book, the GLP-1 medications were just sort of making some headway. So I don't go into that much in the book. There's some citations about it, but we can talk about that in the Q&A. For most people, it's, a good balance of physical activity and healthy eating to maintain weight. I think everyone's aware of the importance of quitting smoking as a strong risk factor for heart attacks and strokes. One of the additions to the AHA's guidance is that healthy sleep promotes healthy eating. It promotes more physical activity, has many, many benefits, and so that's an important component. I added 3 things here that were not in Life's Essential 8. As I mentioned, sort of the research around alcohol has become stronger, that moderate drinking does not help heart health, so less is best. Well-being or self-care is important for heart health, so taking care of yourself, leveraging your support system. And then sort of a bottom line issue is even in people with genetic risk that engaging in healthy behaviors and working on prevention from early in life, one can potentially have a normal lifespan. So screen like it's cancer. I highlight here the three other parts of life's essential eight, which are really controlling these essential numbers around blood pressure, cholesterol, and glucose. These are really the big three growth factors that promote these atheroma or plaques to grow and become inflamed and become more likely to crack or rupture and cause heart attack or stroke. And then just highlighting here, you really need to know your numbers. Normal for blood pressure, less than 120/80. An ideal, so LDL is what we can call sort of the bad cholesterol. So the ideal for that is to be below 100. And then for glucose, an A1C is one of the measures. There's also fasting glucose measures, but for A1C, it's to be less than 5.7%. And it's important not just to know those three numbers, but we have what's called a risk score. So in the bottom of the left of the figure, there's an app that you can download called ASCBD that's put out by the American College of Cardiology. This lets you calculate your 10-year risk for having a heart attack or stroke. And it's something that ideally your doctor will do, but I know that doesn't happen as much as it should. So it's something you can do yourself. You do need to know your numbers as above, but otherwise it has a few other questions about age and sex, etc. And here, that's many ways how we start. And I'll have a later slide that goes into a little bit more detail how we use this risk score. But beyond this, then when people are at higher risk, certainly in our preventive cardiology clinic at Stanford, depending on how high your risk, we can either think about treating or particularly in people who are sort of between this low and high risk score, that a coronary artery calcium scan, and again, we'll go into that a little bit more, but that can be used to detect whether this atherosclerosis has started, and then the amount we use to actually now, and I'll talk about a recent paper that came out just recently, we can use that to stage heart disease, much how we think of staging cancer. Stress testing is really not recommended as a screening test. It's helpful if you have chest pain, particularly chest pain where you exert yourself, as a way to look to see is that chest pain from a narrowing in the heart artery. But as you saw from the earlier pictures, we really don't want to wait till your arteries are narrowed. And there can be a long period of time where there's plaque in the blood vessel wall that puts you at risk that a stress test will not pick up because the blood flow is still adequate. Our arteries actually tend to enlarge in the beginning when you form plaque. So stress testing will not pick them up. So give you and your doctor a false sense of security that there can't be a problem when indeed there could be quite a fair amount of plaque development. And then I think one of the interesting areas, particularly with AI, is that many of the tests that you might get for, say, a lung CT scan, or we talked about a mammogram, or the company where I'm chief health officer, we're working on retinal imaging, that these can be analyzed for cardiovascular disease and cardiovascular risk, even though one is looking for lung cancer or breast cancer or for eye disease. And particularly leveraging AI to automate that analysis. So it's an additional way that one can pick up early disease. And then I think the other area where we need to learn from cancer is that I think because aspects of heart disease we think of as preventable, we tend not to take heart disease as seriously as cancer. I'd say, in our preventive cardiology clinic at Stanford, when we see early heart disease, say on a coronary calcium scan, we strongly advocate to look at therapy to reverse that disease, reverse the biology, reverse the inflammation. And as I sort of describe here, it's instead of these plaques becoming malignant, we want them to stay benign. And the most potent way we have to do that is to lower the LDL, the bad cholesterol. It can reduce the risk for heart attacks and strokes by 40 to 50%. And we'll talk about this staging aspect, but the higher the risk, we think, then the guidelines have us target a lower LDL to even more strongly reverse. And then the other growth factors we talked about, which is control the blood pressure, keep that below 130/80, control blood glucose. This sort of initial pre-diabetes can actually be halted or reversed with things like a diabetes prevention program. And if one has diabetes, then keeping the A1C below 7%. Inflammation, I've mentioned many times, is a key component of these more malignant or dangerous plaques. There are some anti-inflammatory drugs that have been approved, and I'll mention that. But this is an area of still ongoing research that to give us more ability to reverse plaque growth. Aspirin is still recommended, particularly after you've had a heart attack or stroke, because we talked about how a blood clot forming is part of the problem, and aspirin reduces your risk for forming that blood clot. In someone who's not had a heart attack or stroke yet, then aspirin is primarily recommended in sort of before the age of 60 and in those at higher risk. So if you have quite a number of risk factors. And then unfortunately, sometimes people do present with a blockage or a stenosis. And studies, some led through Stanford, have shown that medical therapy can work just as well as an invasive procedure like bypass surgery or a stent. So this should really be a shared decision with your provider as the best therapy. And really, even if one has a stent or bypass to deal with a specific blockage, you do need to think that it's a more systemic disease. So you can treat some spots in the heart arteries, but if you really want to stop the disease, then we really need to reverse the biology with the medical therapy component. I mentioned the sort of early detection and staging of heart disease, more like cancer. So this is a figure adapted from one of the guideline articles that we use calcium scoring in this sort of middle risk group. So if your risk score is low, and then we can keep track of your risk score, try and keep healthy behaviors, track your numbers. But as soon as your risk gets elevated, we consider a calcium score. If your risk is already high, then it's really best to be on therapy. And so the score wouldn't necessarily change that. Some recent developments here, several of us from Stanford participated in a conference that's trying to bring together, using this calcium score from the chest CT for heart disease, and integrate that with the same chest CT that's used for lung cancer screening. So can we more intentionally create protocols so you get screened for both heart disease and lung cancer at the same time? And then my colleague at Stanford, David Marin, was the lead author from a call to action. This is part of a California initiative on improving heart disease care and really proposing a staging system so that we can personalize these preventive interventions. So don't want to go into all the details here, but this level of calcium score indicates how much plaque is in the heart arteries. And so you can see stage 0 through 4 and corresponding higher scores. And so the way to personalize, or you increase the intensity of therapy to get to a lower LDL target. You can see even driving down to getting LDLs below 55. And then in more advanced stages, to consider adding an aspirin for the extra benefit of preventing the blood clotting. And then colchicine is one of the anti-inflammatory drugs you may have heard used for gout, actually has been shown to reduce heart attacks in people with more advanced atherosclerosis in their heart arteries. I won't go through this in detail. It was just nice timing that shortly after the book came out, there was an article in one of the cardiology journals by an author who, had a very similar notion that we've tended to focus too much on this late stage disease when there's already stenosis, potentially because that's where, we have the stents and all the invasive technology. But, as a prevention person, I want us, and if we're really going to reduce the burden of heart disease in this country and around the world, we need to focus on early disease detection. So you can see he talks about as soon as you can pick up early disease, let's try to, more like cancer, you do have sort of induction chemotherapy, get us back to healthy arteries so that we have a nice long life. If we don't catch it early, then it's more like what happened to my father-in-law, that you can have a heart attack, or actually my mother-in-law had an early stroke. Thankfully, she survived well, but yeah, the consequences of not picking it up early and on preventive therapy. So it's nice to see, more emphasis on how do we detect early so we can reverse, so we can have long, healthy lives without heart disease. I'll touch a little bit on digital health and AI. That's an area that I've spent a lot of time on in the last several years. We, with the American College of Cardiology and the Consumer Technology Association, wrote a guide on best practices for how to use these technologies for cardiovascular health. But right, the idea is, like with self-driving cars, we now have more sensors, we have high-powered computers, even right is the computer that we carry around that we call our phone. All of those can help to continuously monitor our data and hopefully steer us towards good health. Apps, mobile apps are, since we're looking at our phone all the time, can help provide guidance. And, my vision is, how do we have a preventive cardiologist sort of sitting with you, helping monitor your data and help catch things early. And right, AI can analyze way more data than humans can, so can detect problems sooner and better. And computers are actually also better at following the guidelines, which, is obviously key. We put a lot of time and effort to coming in with the guidelines. And if it takes years to get everyone to start following them, we've lost a lot of people in the process. And so ultimately, our goal is more of a self-driving health or a co-pilot to help you. And I pull up here one of this just came out 2 weeks ago with some Stanford authors that showed, the new generative AI technologies where you can provide information to these generative AI models, or large language models, as they're called, that the study showed you could actually do just as well, if not better, than cardiologists in diagnoses. And so this idea that we could democratize the ability of having an expert cardiologist to many, many more people around the US and around the world through these technologies. Just some quick examples we had done at Stanford, where we had launched with Apple, being able to monitor your physical activity and give you your risk score. And this was where, we reached within first 24 hours of launching this app, we reached 10,000 people. So it shows you the power to reach many, many more people and really democratize access to health. These are some examples of how in the heart rhythm monitoring space, we've came out of Stanford Biodesign, being able to have a small sort of Band-Aid size patch that can monitor your heart. You can use the finger over the camera on your phone to actually track the pulse in your heart. This is from a company called AliveCor that first put an ECG on the band of a smartwatch, and then one of the companies that I'd worked for as part of Google, we actually built the ECG into the crown of the watch, so you could track your activity and do your ECG and monitor your rhythm. Many of these technologies all came together in basically using these consumer devices and signing up for research studies through your phone, so that when I was with Google and Fitbit became part of Google, we published that we could use your Fitbit to detect an abnormal heart rhythm, what we call atrial fibrillation. And this study recruited over 450,000 patients in under a year, using the fact that many people have these devices and can connect through their phone. So it's really changed the landscape of how we can do large-scale health research and bring these really medical advances to consumer devices. This was in the retinal imaging space. When I was at Google, we had published that analyzing images of the retina, where you see these blood vessels in detail, that if you give these to the computer and say which ones had heart attacks, which ones didn't, or which ones had high blood pressure, which ones didn't, the computer could ultimately learn to identify, just like it can tell cats from dogs, it could tell different retina, and ultimately you could give it a retinal image and it could say which patients had an increased risk of having a heart attack or stroke, very similar to the standard risk score that we were just talking about. Part of the reason I work for this one startup that's still doing the retinal imaging is I've wanted to take this technology, which right now, was just in a research study, and bring it to a product. So we've published on that and are working with the FDA and starting a clinical trial so that we can hopefully bring this technology to patients. And then the last items is, there's what are the bigger picture things that we can be doing? So we need to be promoting more physical activity and healthy nutrition, especially for our youth. We need more equitable access to healthy foods. There's a big food is medicine initiative. One of the things that you can do for yourself or for those around you is every man over 50 or woman over 60, do they know their numbers? Do they know their risk score? And what I say is you should probably either be on lipid-lowering therapy or have a negative screening exam like a negative coronary calcium score. I also talk about how we have a condition of familial, so genetic, very high cholesterol that's actually quite common in the US and very lethal. The CDC has recommended a cholesterol check for every child after age 9, but it's actually not happening. So again, if you know any children who are 9 and above, and make sure they've had their cholesterol checked. And then the last is, I'd really like us to talk more about combining prevention of heart disease and cancer. And it's really about getting your healthy daily cycle of physical activity and sleep, be mindful of what you put in your mouth, and get screened appropriately when appropriate. And that helps prevent both heart disease and cancer. And then, yeah, just so we can all be there for important events like my daughter's wedding here. So I'm going to pull up some questions, I think. So I saw in the Q&A, there's what tests can we recommend for inflammation? It's interesting. One of the tests in the guidelines is the high sensitivity CRP. So it is considered a risk enhancing feature or factor. So that is one metric that one can use. As mentioned, there's been research on trying to be able to directly image inflammation within the plaque itself, but that's still ongoing research. Let's see. I know there were some questions that have been submitted earlier. Someone asked about lipoprotein little a. That is another risk enhancing factor. We basically use that to sort of add to this concept of staging a risk assessment. So if you have, say, a modest risk score, but you also have a very high LP little a, then we move you to a higher risk group. And so the recommendation would be to treat more aggressively to a lower LDL target. I have a whole discussion in the book that I have a very high LP little a, so I've used that to initiate treatment sooner. Unfortunately, I passed it on to both of my daughters. So importantly, they're aware, and hopefully, motivation around I'm here at this conference in Chicago, and part of it is last weekend, they both just ran the marathon in support of the American Heart Association. So they're trying to do their preventive activities. I know there was a question around physical activity and the right kinds of physical activity. I'd say the most important thing is something that you like to do that you'll be able to keep doing. And what I talk about in the book and mention briefly is you really want to do activities to get your heart rate going. So the baseline is, say, a brisk walk, what's considered moderate activity. And that's where getting 30 minutes most days a week towards that 150-minute goal. You get more benefit from more minutes. Even 75 minutes a week still has significant benefits over completely sedentary activity. And I like to say you get double credit if you make it vigorous activity. So lap swimming or singles tennis or jogging. So the more intensity gives you more benefit. And I think there was part of that was if you've had a heart attack, are there things you recommended not to do? So aerobic sort of physical activity like, walking is important. Some degree of weightlifting is important, but we tend to recommend against heavy weightlifting, which tends to raise your blood pressure. So in patients with cardiovascular disease, keeping it mostly aerobic activity with some weight and strength activities, but not using super heavy weights would be the recommendation there. Sorry, someone said, good question, what is medical therapy? So medical therapy is really medications to target those big three growth factors. So medications to lower your cholesterol. So statins are the most widely known. There are some newer, more potent medicines that also take more of the bad cholesterol out of your bloodstream. The other parts of medical therapy are controlling blood pressure, controlling blood sugar if they're elevated. And then I mentioned if you have more advanced disease, then aspirin or a similar medicine to reduce the risk of the blood clot part forming. So those are the sort of medical therapy that's recommended, certainly when you have significant plaque buildup. Let's see. What percentage of the population should be on a statin? It's a good question. I guess I haven't done the back calculation there. What I do know is what I mentioned earlier, right at the outset, is only about 1 in 3 of people where guidelines, where 1 in 3 people who are eligible, meaning that they have higher risk scores or they have plaque development, only about 1 in 3 are actually being treated with, and the main form of preventive therapy is a statin, or to get their LDL down so it reverses the plaque growth and prevents heart attacks and strokes. In those who've already had a heart attack or stroke, we're still, there at least about 7 or 8 out of 10 are on good preventive therapy. But we're really not doing a good job in helping the people prevent that first heart attack and stroke. Let's see. Sorry. Oh, will AI help on plaque severity score? So great question. They're actually Stanford's Dr. Marin, I mentioned, is involved in a study of, so there is a more advanced form of the CT scan that involves squirting dye in the heart artery, in the vein. So you get really a non-invasive angiogram, and that sees more detail of the plaque that's in the heart arteries. And so there are companies that have developed AI algorithms to sort of quantify how much plaque is there, quantify how much looks like more inflamed or more lipid-rich plaque, which we view as sort of the more malignant or risky plaque. So there is a study going on of what kind of changes happen over time on this CT angiogram measures of atherosclerosis. And would that in the future be a better way to guide, how intense the therapy, to see, if the treatment that we're doing is working well. Would you recommend taking colchicine as prevention even when you have a lower CAC score? In someone who's not had a heart attack or stroke and has a lower CAC score, we don't have the clinical trial data yet to say. And, with many interventions, they usually start out proving something works in the highest risk group. And then over time, there are more studies that are done to try to show, does it help in your, does that same medicine work in lower risk groups? And at this point, I don't know the answer because we don't have those studies. And as mentioned, there are some other anti-inflammatory kinds of medications that, are still in clinical trials. Are lifestyle changes and diet and exercise more effective in preventing heart disease than consumption of statin? You know, the trials that were done with statins, you know, advocated healthy lifestyle plus placebo or plus statin. So the statins added to them. You know, we do think that if one sort of what's called primordial prevention, or what I like to call more proactive prevention, is, you know, early in life, being able to engage in healthy lifestyles makes it, you know, much more likely that you'll be able to go a long time without getting to a point where you may need a statin. So I think of them as complementary, and certainly the guidelines and part of the, in the summary of that staging and treatment, you know, all the groups, all the stages is still recommended to follow Life's Essential 8, both the lifestyle and controlling, you know, trying to keep your numbers good. And then we primarily do the statins when there's evidence of plaque having developed. There's a question about if I have a calcium score of 0, can I have atherosclerosis? The answer is yes, in that the calcium score just picks up calcified plaque. So which is typically sort of part of the aging of a plaque. So you can have some non-calcified plaque. Importantly, if you have a calcium score of 0, your risk of a heart attack or stroke is very, very low over the next 10 years. So while it's possible that there's some plaque there that the calcium score doesn't detect, the risk is still very low. But that is an area that, like a CT angiogram that can see non-calcified plaque, that's an area, you know, that will probably still be more research of which patients where it may be beneficial to look for, you know, non-calcified plaque. I know we've gone a little over, and I'm sorry if I didn't get to all of the questions. But yes, there are a lot of this is covered in the book. There are many more chapters than we had time for this talk. And yeah, so I hope it's been informative, and I hope you'll take the information to heart, as they say. So, but yes, thanks for your attention, and take care.